organ. Fat is an active inflammatory endocrine organ. And what that means is when you're carrying extra weight, even if it's only 10 pounds, 20 pounds, things that we would consider as modern Americans to be not that much weight, that fat is actively trying to kill you.
This is MedSpa Mayhem, the podcast all about the chaotic world of medical aesthetics. From Botox to lasers to IV bars, learn how to tell real versus fake, legal versus illegal, and safe versus potentially deadly. Hear the crazy stories inside the med spa world and find out what questions to ask and how to spot the people cutting corners. I'm your host, Dr. Kate D. Together, we explore the wild west of medicine that is the aesthetics industry. Hi, this is Dr. Kate D, and I'm so excited to have Dr. Flora Waples back on the podcast today. We had a fantastic conversation a few weeks ago about salmon sperm, or PDRN for those science geeks out there. And that was, that dropped on July 9th of 25. That was series 3, episode 8, in case anybody's interested in salmon sperm topic. But we had so much to talk about, Dr. Waples and I, because we really got into a topic of wellness, hormones, longevity. And so we're back today to talk about that. So Flora, thanks so much for being here today.
Well, thank you so much for having me.
Yeah. And just to remind, Dr. Waples has Restor Medspa in the Denver area. I think you've got 3 locations right now and you're about to open up a 4th one. Yep. So super exciting. And you've been doing this for how long now?
Oh gosh, almost 14 years.
14 years. So
almost
yeah,
14
even
years.
Longer than me. And what's interesting about the space that we're in is that we left traditional medicine behind kind of a long time ago. Mm-hmm. And both of us brought in like real science into our aesthetic practice. So that's very well founded, right? Mm-hmm. But we're no longer bound by what Medicare and insurance companies will pay for, right? And so there's a lot of medicine that's maybe like at the edge of innovation. And I really think longevity medicine is in there. It's like there's so much science, not a ton of studies. People are kind of experimenting with what works and what changes things. So can you tell me a little bit about your journey into that part of medicine?
Yeah, absolutely. I can tell you exactly when I decided to enter that branch of medicine.
Like when you turned 40.
Essentially, yeah. And this is something that I know that you will sort of immediately recognize. Our medical system, modern medicine, was developed in the early 1900s. Right? That's when medicine passed into real science, and it was developed to treat disease. And that was the crushing need of humanity at that time. And it was really, really important. So we have this entire medical system built on treating disease. And again, really important. If you got disease, there needs to be a treatment. That's
absolutely. Very, I mean, it used to be people died of infections.
Yeah, so, in their 40s, right?
Very few people die of infections anymore.
Yeah, so it's an incredibly important thing. But the treatment of disease has given us 40 extra years of life. Our lifespan has doubled in the last 100 years. That's an incredible gift. But the years they have given us, unfortunately, are not very good years. We can knock down disease, but we have not figured out how to extend health and vitality, right? That's the
Hey, now wait a minute. As a 57-year-old, I'm still in like pretty amazing years right now, but okay, sorry to interrupt you.
So generally people, we're healthy and vital through our 40s into our 50s, and then we start to decline. The way we feel and function declines. So when I hit 40, everyone in my family gets diabetes. My family, literally every single person in my family has type 2 diabetes in their 40s. And so I was I gained about 30 pounds. My hemoglobin A1C, which is a blood test that we use to measure how close someone is to diabetes, was kind of steadily going up every year, just kind of tracking up. And so I went to my primary care doc, who also, by the way, smart woman, good doc. We trained at the same institution, like she's a good doc and she cares, and so I said, hey, I'm gaining weight. I can't sleep at night. My hair's falling out. I have no desire for my partner. I'm pre-diabetic. Everything's just falling apart. We need to do something about this. And she said to me, she's like, well, Flora, she's like, you're a woman in your 40s. Like, how do you expect to feel? Like, you're pre-diabetic. We don't treat that. We're going to let that run for another 5 or 6 years. When you develop diabetes, we'll treat it and we'll put you on the GLP-1. She's like, but right now we just kind of watch. And I was like, oh. Yeah, right. And that, because that's what people like when someone comes in, their cholesterol's getting high, their blood sugar's getting high, they're starting to feel these symptoms. Traditional medicine's answer is we do not treat aging. We treat the diseases of aging. So we're going to let that run until it becomes a full-blown disease, and then we'll treat, right? And I did not want to put my body through another 5 years of slowly escalating, high blood sugars and all that kind of stuff, to wait until I developed diabetes, took that hit, and then treat. I was like, no.
Right.
So that's when I went back to school, did a fellowship. I put myself on GLP-1s, put myself on hormones. I am now no longer pre-diabetic. I intend to never become diabetic, but it's a different way of looking at medicine. The traditional sort of paradigm is you treat disease. But I believe that we really need to be transferring into a model where the goal of the physician or the caregiver is to stop those diseases from ever occurring in the first place. In order to do that, you need to start way earlier than we do. So that's where my journey started. And it's just been absolutely fantastic. 5 years ago, 30 pounds overweight, pre-diabetic, I couldn't run a mile. And in 2.5 weeks, I will be running a 40-mile ultramarathon here in Colorado.
Oh my God. Wow.
None
That's
of that
amazing.
it's only because I have been able to change the way my body functions. And that's been a tremendous, I've just been so excited about it. So, yeah.
Okay. So I'm super psyched to talk about this with you. You said that you put yourself back in school to study. So what did you do at the time to become educated on this?
Yeah, absolutely. Well, I did a hormone replacement fellowship. I did that first. And there's not a lot of very well-developed programs out there because
Hmm.
preventative medicine is not supported by insurance. And
Yeah.
longevity medicine, like you said, is outside of the sort of what I would call the standard medical, paradigm. And because of that, yeah, there are no residencies. There are no supported degrees. You can't get reimbursed by insurance because there's no disease code to attach to it, right? So it's all got to be out of pocket. It has to be kind of ad hoc. So I did a fellowship in hormone replacement therapy. I started going to conferences, and I just learned that there's an entire branch of medicine out there that, yeah, some of it is absolute crap. You got to be able to be skeptical and treat it with, some
Yeah.
skepticism and critical thinking. But there's a lot of it that's really, really good and is underutilized, tragically underutilized in our society. So,
Yeah. Okay. Well, so I'm curious to know, you want to talk about, or maybe we'll use me as an example. Okay. Maybe I'm coming to you as a patient and we can go through what you might advise me to do. Because I'm actually pretty healthy at 57. I'm super active. I eat well. I already do a lot of exercise. I do strength training twice a week. And I try to get exercise almost all the other days. Although I do put in rest days here and there when I need them, or when I'm just too busy, which is sometimes happens. But I will say that I started entering perimenopause. My guess was in my 40s, and I just didn't know it. So even as a
yeah.
physician, I just kind of didn't recognize the symptoms because I still cycled like clockwork. And I even went to my doctor a few times in there for various things. And it's like, oh, well, we don't even worry about it until you skip a period. And then I
Mm,
didn't skip a period until the month I turned 55. So I
yeah.
suffered from a lot of symptoms
Yeah.
for probably about 15 years. So let's just start with that. Like, what would you advise people to do in their 40s before
Yeah.
everything has
Absolutely.
stopped?
Well, first, I'd just like to say your experience is the rule, not the exception. Perimenopause typically, the symptoms of perimenopause typically last on average actually about 15 years. You're like spot on for the average. And yeah, in sort of the traditional medicine paradigm, you don't start treating until it's full menopause. And so people have, 10 or 15 years where they're really quite physically miserable. I mean, like I can speak to my own symptoms. Yeah, I was waking up every night between midnight and 1 or 2 in the morning. I'd be awake for 1 or 2 hours. And then, I
Yeah.
couldn't function as well during the day. I was gaining weight. Estrogen is one of the main hormones that provides for that maintains insulin sensitivity. And when our estrogen levels start to drop, our insulin sensitivity drops, we start gaining weight, right? So we can't sleep. We're gaining weight. As other hormones in our body are dropping off, our metabolism starts shifting so that instead of taking in calories, burning them as energy or burning them to create muscle or bone or whatever our body needs to do, instead we're storing those things as fat. So we're tired and we're gaining weight, which is like this horrible combination, right? And
Yeah.
all those things, and then
And I
hot
think your
flashes.
brain suffers too.
Oh,
I just feel
absolutely.
like it's chronic less sleep, you're heavier, you have more physical issues, and then your brain suffers. I just feel
Yeah.
like I was just, wasn't as sharp. I don't know,
Yeah.
at times
No,
especially.
that is not that has been proven on MRI. Estrogen is absolutely vital to maintain white matter, which is sort of I think of it as the wiring in our brain. And when it starts to decline, the amount of white matter, the robustness, that's not sure it's a word, but the robustness of the connections between our neurons start to decrease. I think of it as if you have like mice in your walls and they're chewing on the insulation in your wires, like you're going to start having shorts, right, in your house. And that's what
Right.
happens to our brains as we lose these hormones. And I had this amazing experience where, you get those 6-digit codes on your phone, right? Every time you try to log in somewhere, they'll send you a 6-digit code. You got to type it in. And I couldn't remember the 6 numbers long enough to type it in without looking back at my phone. And then after I'd been on hormone replacement for about 6 months, like all of a sudden I could remember those 6 digits again. And it was one of those things where I was like, wow, there really is something to this. But yeah, having those symptoms early is very, very, very common. And so to kind of take a step back and sort of take that 10,000 foot view, especially for the non-medical people in the audience. Hormones, everyone knows the word hormone. Everyone kind of has a sense that they're these things that kind of govern processes in our body. But I like to go a little bit deeper than that to explain why hormones work the way they do. So I like to think of the body as a factory. And you take raw materials in, there's all these machines inside your body that would be like the machines on the assembly line that are working together in concert to create all the processes your body needs to do. And the output is your body can do the things you ask it to do. So in that analogy, all the machines on that assembly line, those are your genes, right? Your genes are responsible for making you you. Your genes are responsible for every process that your body is capable of doing. Now, taking a step kind of above that, hormones are the instruction manual. They tell genes when to turn on and when to turn off. Now, this is a little bit of an oversimplification. There's other things that turns genes on and off as well. Environment, lifestyle, exercise. There's a lot of things that go into this, but hormones are one big piece that turn genes on and off. So when you get to your 40s and all of a sudden your hormone levels start dropping off and becoming very erratic, it's as if someone was walking into that factory and just ripping pages out of that instruction manual. And now all of a sudden the machines can't work together the way they're supposed to. And in my head, I have this picture of like gears grinding and like smoke plumes are coming up all over the factory. And your ability to do the things that you want your body to do starts to drop off. And that process continues from about our, sort of late 30s, early 40s until our deaths. Right? That's an ongoing process. When we do hormone replacement therapy, what we're trying to do is by giving your body back the instruction manual, now the genes can work together again in the way that they did in your 30s. And what that means is you can feel and function the way you did in your 30s. And again, it's not perfect. It's not all the time. It's not going to last forever. The end of the journey is still the same. But the goal is to give you as many good years as possible. And so that's what we're trying to do with that. So my advice to patients when they're coming in their 40s with this series of issues that almost sounds like the definition of what we call getting old. I'm tired. I'm gaining weight. I can't sleep. I don't feel good. My hair is falling out. I can't exercise. My muscle mass is it's hard to maintain muscle, like injured all the time. All of those things have to do with the loss of gene function that follows declining hormone levels. And they are all reversible. They're all reversible. And I would want my patients to know I can change all of that for you. I changed all of that for myself. I changed all of that for my loved ones. And that would be the place where I would start.
So we're obviously talking about estrogen and progesterone
Mm.
here for women. What about testosterone and
Yes.
also what about other hormones?
Yes. Testosterone, you are going to get me on my soapbox, Catherine, because it makes me crazy how, okay, there is no FDA approved use for testosterone in a female. Females make testosterone. We make more testosterone in our bodies gram for gram than we make estrogen. The idea that somehow that there's no FDA approved medication for something that our bodies intrinsically make and use every day is ludicrous to me. Like, how is that possible? But that aside, yeah, testosterone vastly important for women. It is one of the first hormones to drop off. And the way I think about when I talk to my patients about their symptoms, I break them into categories. Testosterone is the engine. It's the engine for males and females. It's not the steering wheel. It doesn't tell you what to do. It gives you the drive and energy to do whatever it is that you choose. So testosterone is athletic endurance. It's athletic ability, helps with bone density, Libido, absolutely, both men and women, but it's the engine and the motivation and the drive to get you out and get you moving. Thyroid is another hormone that is really vastly, I think, undertreated in females. Women have thyroid dysfunction at a rate that's 5 times that of males. It's actually very, very common. No one is really exactly sure why. We think it has something to do with the immunologic changes that happen to our bodies during like pregnancy, but no one really knows. But thyroid is our body's thermostat. It's the hormone that tells our body whether we should be burning our calories as heat and fuel or whether we should be storing them as fats. And as our thyroid production drops off in life, which again happens to almost all ladies in midlife, not all, but a significant percentage.
Oh, mine started in my 20s,
When
but
you're
you
starting
know.
your 20s, it's so common. Thyroid dysfunction is so common and vastly
Yeah.
undertreated. And it leads to a feeling where people feel like they're just like wading through cold mud. They're cold all the time. They're tired all the time. They're gaining weight. It's very difficult to get things done. When thyroid is optimized, now your body's thermostat is set correctly. You have energy. You're warm. Your brain works. And you
Yeah.
don't need to sleep all day. And then
Imagine going
estrogen,
through residency with low thyroid levels. It's really
I can't. It would just
nearly
it forces
impossible, but I
will.
managed to do that.
I
Yeah,
mean,
it's
it would be
terrible.
very, very, very hard. I can only imagine. And then
It was hard.
estrogen and progesterone, those are the hormones that are classically linked to what we call the classic perimenopause symptoms. That's your hot flashes. That's your irregular vaginal bleeding. That's your vaginal dryness and loss of vaginal lubrication, frequent urinary tract infections, all of those kinds of things.
Well,
So
and
when I
also
talk
sleep, like progesterone is huge for sleep too.
progesterone is huge for sleep. And so when I talk to my patients, I kind of gather all their symptoms and I kind of try to get a sense of how are we doing for, the perimenopause symptoms? How are we doing for energy, athleticism, libido? How are we doing for metabolism? And from that picture, I decide which combination of hormones they need to be on and why. Generally speaking, most of my premenopausal women are on progesterone, testosterone, and a good chunk of them are on thyroid. And then for postmenopausal women, I add estrogen on top of that. And
Hmm.
then around that, we kind of wrap this, metabolic disease is the underlying cause of almost all other chronic diseases of aging. Metabolic disease underlies cardiovascular disease. Metabolic disease underlies a large chunk of oncologic disease and neurodegenerative disease. I get this from Peter Attia. I didn't make this up. This is not my own
Yeah.
invention. This is his. But we are very, very aggressive about controlling blood sugar and about controlling cholesterol, risk stratifying for cholesterol. So our goal is to use the hormones to make people feel good, give them the energy to do the things they want to do. And then in the background, we're going to help manage their blood sugar. We're going to help manage their cholesterol and cardiovascular risk. And that's how we're going to provide for not just length of life, but also hopefully quality of life. And that's our program.
Yeah, I think quality of life, extending happy, active
Yes.
days of life, not extending life even though you feel like crap or you're
Right.
dying. We're just extending. I mean, the worst thing for me during my medical training was realizing how much we were just prolonging the torture of death
Yeah.
for
We, we,
people in the
we torture
hospital.
old
And
people to death.
oh
Yeah.
God, and I
100%.
couldn't be a part of that. It just was so painful for me. So that's how I ended up doing
Yeah.
breast imaging and breast cancer for so long, because it was generally we saved people's lives and people went back to having a normal, happy, successful,
Yeah.
active life. And that was the part I could play. But like, I really think that helping people live healthier longer is just, it might be the best possible thing we could do. So, I mean, I have so many questions. Do you test everyone's levels, and do you test them before and after you put them on the various hormones? And what are the ideal levels you're looking for? Are they different
Yeah.
at different ages? And not to get too into the weeds with this, but I'm very curious because a lot of people go on, and myself included, my doctor, I have estrogen and progesterone and a little bit of testosterone as well. But like I'm not testing my levels. Should I be?
Well, that's a fascinating question. And, I'm trying to think of the best, most concise answer to that because the short answer is, do levels matter? The answer is yes and no. And the reason why is this. As we are learning more and more about sort of genetic polymorphisms and how distinct people are in their genes, what we're realizing is that the blood levels of a lot of molecules aren't necessarily going to tell us how well they're working. So for example, let's just use
Mhm.
blood pressure as an example, because we've both treated like thousands of people with high blood pressure, right? Someone comes in, they got a hypertensive crisis or whatever it is. You give them 20 labetalol, you wait 15 minutes, you check their blood pressure. If the blood pressure is still high, you give them another 20 labetalol, right? You continue to increase the medication until you get the clinical response you're looking for. We treat the clinical response in a lot of situations, right? Blood sugar, high blood pressure. There's a lot of things we do that with.
Yeah,
Um,
absolutely.
and that is, I think, the gold standard, because different bodies respond very differently to different doses. So when
Sure.
it comes to hormones, the hormone levels in someone's blood, I believe, and again, I'm a little bit of a zealot here, so take everything I say with a grain of salt, but I believe that the hormone levels in someone's blood are almost irrelevant. And I'll tell you why I believe that, what the science behind that. Hormones don't work in the blood. They have to get absorbed into the cell, bind to the nucleus, and act on the genes directly. That's how hormones work,
Right.
right? So the question, so if somebody has let's say a testosterone receptor, for example, or thyroid's a better example, someone with the thyroid receptor. I think of it like a little baseball mitt that's sitting on the outside of the cell, and the thyroid hormone's coming by in the bloodstream, and the cell grabs it and pulls it inside, right?
Yeah, exactly.
There's good data that says that different people have receptors, really different quality. Some people have
Hmm.
got like a starting catcher for the New York Yankees. Every time a thyroid hormone goes by, their cell's going to grab it. Their blood levels and their tissue levels are going to correlate really well, right? And those are people that doctors love, because we do the blood test, and the blood test says they're doing well, and the patient says, yeah, I feel great. And it's like, cool, everything works, right? But there's
Yeah.
people, a lot of people, probably about a fifth of people, who have, like Bobby from Little League hanging out there, and he's looking at the flies. He's not paying attention. The hormones are just zipping by, and they catch maybe 1 out of 10, right?
Right.
Those are people where their blood levels will say the blood levels are normal, but it's not getting into the cell where it needs to work. And that's a situation where the doctors can, typically the doctor says to the patient, hey, your labs are all normal. And the patient goes, but I feel terrible. And the doctor's like, well,
Right. Right.
your blood levels are normal, right? And that conversation happens a lot, especially with thyroid, because there's so much difference in the receptor sensitivity. So I draw labs, I look at blood levels, but I also then turn to my patient and I say, tell me what symptoms you're having.
How do you feel?
And
Because
exactly,
don't the receptors can up or down regulate as
they can
well.
up or down
Do you have
regulate.
any control over that? Can you influence how the receptors are,
Uh, I don't
responding, or
know if
no?
people can. I can't. I know that one thing that people do is they'll do holidays, right? Where, well, they'll treat for a month and then take it off for a month, and treat for a month, take it off for a
Hmm.
month. And I understand the
Yeah.
idea behind that. So when you withdraw the hormone, your body puts more receptors on the cell surface to try and catch whatever's left, because the
Right.
body's hungry
And
for it.
and we
Makes
do
sense.
that separately with skin with
Yeah.
tyrosinase inhibitors. You
Yeah.
need a little
Exactly.
holiday for a week for the receptors to upregulate again
To
because
become
they
more
get,
sensitive.
yeah.
Yeah.
So I'm just curious
Yeah.
whether, as we get healthier, let's say you go on GLP-1s, you lose 20 pounds, just
Yeah.
theoretically,
Yeah.
and then your blood
Not that I've
pressure
ever had
goes
any
back down to
experience.
normal and your cholesterol goes
Yeah.
back to normal. I'm kind of wondering if your receptors change in their regulation as well. I'm
Yeah.
guessing they probably do as you get
Almost
healthier.
certainly they do, because that's the feedback loop that our entire body is generally
Right.
based on. But here's my argument. And again, there are multiple valid different ways to deal with this issue. My personal feeling is, if I give somebody 1 month off out of every 4, what that means is a quarter of their time they're not going to be getting the benefit of this hormone. I would
Mm,
prefer to just go ahead and increase my dose so that I maintain their clinical status as stable. Not saying that giving people holidays is wrong, just saying I personally believe that if I believe this hormone is important, if I believe that it's about adding to your quality and quantity of life, I don't want
sure.
to withdraw it for 1 month out of every
Right.
4. I just want to
Well,
go ahead.
maybe do 1 week every
You
6
know,
months.
but then you feel like ass for a week. I feel if the tissue is what matters
Yeah.
and the patient's symptoms are what matters, I treat the
Yeah.
clinical result. And again, I'm not saying that this is the way that everyone has to do it. I'm saying that this is my
Sure.
personal, way. Is if I'm treating for clinical result, I treat for clinical result, period. Whatever the dose is, whatever the blood level is not as relevant to me as what my patient's symptoms are. And I find that with hormones, people know when they are at the right level. It's very much
Yeah.
like if you're learning a dance step and you've never done it right before, and then you do it right the first time, you go, oh, yeah, that was it. I know that was right. It feels right.
Right.
And you know it immediately. That is how
It's
most people are with hormones. They know when they're at the right level. And then
And I
I
can
just,
tell you my experience, like with progesterone.
yeah.
I started first on an estrogen patch because
Mhm,
I had a hysterectomy a couple years ago,
mhm,
but I was not sleeping. And
mhm,
so I talked to my doctor, and
yeah.
she prescribed a dose of progesterone
Mhm,
that I slept like a teenager, but then my breasts were so tender, I thought
mhm,
that I was a teenager again. So then I cut that dose down in half, and
mhm,
now it's like this perfect happy medium, right?
yeah.
Boobs feel fine and I'm sleeping really great. But I'm so like I need I need it. I need it to
Me
sleep.
too.
And for me
Yeah.
sleeping is like I feel really sharp and I feel rested and I'm energetic. If I don't sleep, then forget it. It's such a drag.
Yeah, the idea that, because the ACOG guidelines, what they state, I think still state this, is, progesterone is not necessary for a woman who has not had who has had a hysterectomy, who does not have a uterus.
That's what they told me.
That's
I was
ridiculous.
like,
That's the most ridiculous thing I've ever. So what? A woman with a uterus doesn't need to sleep. A woman with a uterus
right.
doesn't need to have like her brain's natural anti-anxiety molecules, circulating. Like that's the biggest bunch of nonsense I've ever heard in my life. I do not believe that to be
Yeah.
like, is it necessary? Do they need to have protection for endometrial cancer? Well, no, they don't. But that's not the only thing that progesterone does.
Right.
Progesterone is
And again,
it's our
that goes
brake pedal
back
for
to
our
our
brain.
that goes back to our disease-centric thinking in medicine.
Yes.
So for those of
Yes.
you at home who didn't quite follow that, so
I get
what
excited.
what happened was people were on hormone replacement therapy for many, many years. It used to be everybody was on it. But if you were if you had a uterus, you have to always have both estrogen and progesterone, because otherwise, if you have just estrogen, your uterine lining can overgrow, and that can be a problem for a lot of reasons, including an increased risk of endometrial cancer. So, but if you don't have a uterus, you don't have to worry about that. So you don't need the progesterone. But, obviously those of us who want to feel good,
Yeah.
obviously we know there are other reasons to have the progesterone other than to just protect your uterine lining. But again, that's disease thinking. That's not healthy
As
thinking,
opposed to
right?
optimized thinking. And I'll tell you, so
Right.
for myself, so progesterone, the way I think of progesterone is the brake pedal. It allows your brain to slow down. So that means it combats irritability, it combats anxiety, and allows you to sleep. When I was in my mid 40s, I started to develop almost crippling anxiety. And Catherine, just to put this kind of into like perspective, like I was ER doc, high altitude alpine mountaineer, like I don't get rattled. Like that is, if there's one central thing about my character, it was that when crises happen, I flourish in high pressure situations.
Yeah.
And then all of a sudden in my 40s, I started to get anxiety, and to the point where I would drive to the hospital for a shift, and I'd be sitting in the car outside the hospital like puking because I was so
Oh
afraid to
my
come to
gosh.
class. And I
Wow.
was like, this is not
That's
me.
terrible.
Like this is not how I'm built. And it was like my brain was a fist. It was just always clenched. It was always like this, and I couldn't relax at all. And I was angry, and there was nothing to be angry about, but I was angry and I was scared and I couldn't sleep. And just, it was a very, my brain was an unpleasant place to live in. Like it was like a bad neighborhood with like broken
Yeah, that's
windows and no street
terrible.
lights, it was a scary place. And then when I started on progesterone, within 5 days, that all went away. And all of a sudden, my
Mm,
brain was a safe place to be again. And that is also very important. Like endometrial cancer, yes, preventing endometrial cancer is important. But to say that a woman doesn't
sure.
need progesterone because she doesn't have a uterus ignores all of her other organs that do need it.
Right.
And I think it's short
Right.
sighted. Yeah.
Absolutely. So let's shift gears a little bit
Yeah.
and talk about other things that affect longevity. And when
Yeah.
I'm going to use that word, I'm going to refer to living healthier longer. So extending your active, healthy life. So can you talk a little bit about the things that you offer in your clinic?
Yeah.
The things that you've
Absolutely.
investigated, maybe some things
Yeah.
you don't use because they don't necessarily
Yeah.
work, or don't have enough science behind them. But this is such an
Absolutely.
interesting area of research right now.
Oh, so interesting. And I will again give all credit to Peter Attia, he is a physician, double boarded, I believe, in oncologic surgery, and I forget what his second boarding is, but brilliant doctor who has done tremendous work in sort of I hate the word longevity. We should call it vitality. We should call it, good life. But his book Outlive was a seller, and I recommend that book to anybody. Yeah, anybody who wants to learn more about this. But I believe his framework is the correct one. And what his basic idea is, and so this is what I based my care off of, and I'll answer that question of what I actually do in a second. But his basic idea is there's four things that are responsible for almost all the morbidity and mortality, the sickness and death in old age. If we take out traumatic injury, so if you're not hit by a car or shot in the head or or something like that, the odds are you're going to die of one of four things. There's only four: cardiovascular disease, which is heart attacks, right? Basically, our blood vessels become clogged with gunk, for want of a better word.
That's a
Oncologic
very
disease,
accurate. That's accurate.
oncologic disease, which is cancers, right? Neurodegenerative disease, which is dementia, Alzheimer's, diseases in which our brain ceases to function correctly. And metabolic disease, which is an inability to appropriately process our calories. Diabetes being, of course, the most well-known from that, but diabetes and obesity. And of those four diseases, Diabetes and obesity are responsible for the vast majority of cardiovascular disease, about a third of all solid cancers, and play a huge role in Alzheimer's and dementia. So whenever you're looking at any patient and you're saying, okay, my job is to stave off, he calls them the four horsemen of the apocalypse, to buy you 10 more years before these guys come knocking at your door. The
Right.
first and most important thing we got to do is address metabolism. Like that is the thing which underlies and undergirds everything. And there's two pieces to that. Visceral fat is the absolute enemy. Right? And when I say visceral fat, what I'm specifically talking about is fat that's generally in our midsection. Not the fat that lies directly underneath our skin, but the fat that's around our organs. Visceral, we think of fat as like this thing that we carry around, like it's a backpack full of food, but fat is an active endocrine organ. Fat is an active inflammatory endocrine organ. And what that means is when you're carrying extra weight, even if it's only 10 pounds, 20 pounds, things that we would consider as modern Americans to be not that much weight, that fat is actively trying to kill you. And there's a lot of fascinating science about why that happens, but it is. And we just carry around inside our bodies this thing which is attacking our blood vessels. The first step is to knock down the visceral fat. That's the first step. Now, diet and exercise, I love it if my patients can do that. I encourage it. I diet, nutrition, exercise, those should always be the fundamentals. However, real life, a lot of people can't do it that way. For a
It's
variety of
hard,
reasons.
especially in after 50. I'll tell you, I mean, I was always able to diet and exercise my way down to a healthy weight. If
Yeah.
I ever, I was always going up and down 20 pounds.
Yeah.
And after 50, I couldn't get it done. I just couldn't do it. And I have a lot of willpower compared to the average bear, but I couldn't do it in my 50s without tirzepatide.
We use tirzepatide. So the GLP-1s, Ozempic, Wegovy, Mounjaro, like the tirzepatide and semaglutide, also testosterone, so that you can build muscle mass again, because muscle mass is the biggest protectant against high blood sugar. Muscles will suck sugar out of your blood, essentially. Those two things. Appropriate thyroid, because your thyroid tells your body whether to burn a calorie as energy or to store it as fat. If you don't have enough thyroid hormone, it's really hard to maintain your weight. So we use the GLP-1s, the semaglutide, Ozempic, Wegovy medications, in conjunction with our hormone replacement therapy to both suppress how much food's coming in and increase how much you burn. And between those two things, the goal is to get the visceral fat out and get the blood sugar under control. And then the next step is to look at long-term cardiovascular disease risk. And so for that, we're measuring cholesterol, but that's not really where it's most important. We're looking at lipo-A, ApoB. We're looking at these other lab tests that allow us to predict with a pretty good degree of accuracy which individuals are going to be the ones that build plaque. And depending on how many risk factors you have for building plaque in your various blood vessels, we are going to be more or less aggressive about managing your blood sugar and managing your cholesterol and triglyceride levels. So, and that's really the backbone. It's not that complicated. Like all we need to do for someone to have a disease-free sort of middle and late life is keep the visceral fat off, keep the blood sugar under control, and manage cholesterol if you have risk factors. That's it. That's all you got to do. And that's the backbone of what we do. And the hormones make it possible for your body to do those things correctly.
So earlier you were saying that there were two big things for people with diabetes, visceral fat, and the second thing was blood sugar and all the sequelae of having okay. All right, make that real clear. So a lot of people probably know that men tend to have more visceral fat as they get fatter. A lot of their fat is inside their abdomen, visceral fat. And then women tend to get a lot more sub-Q fat. Not that we don't get visceral fat, we do. But so is that related to the fact that men tend to get more heart attacks and stuff like that? Like in what way is the visceral fat trying to kill you?
So many ways. So what I would say, I would start, there's two answers to that question. The first answer to that question is estrogen plays a profound role in insulin sensitivity and also in our ability to break down plaque that's forming inside our vessels. Women tend to have higher estrogen levels than men until we hit menopause. And when we hit menopause, if we're not treated, our estrogen level drops to zero. That's why women have lower heart attack risk than men for most of our lives. But then as we get older, all of a sudden our heart attack risk becomes as high, if not higher than men, because we've lost that protective. Estrogen plays the same role in men that it does in women. Testosterone is a pro-hormone. Testosterone itself doesn't really do anything. It's aromatized into DHT, which is muscle and libido, and estrogen, which is responsible for the bone mass protection and also for the cardiovascular protective effect. So with men, testosterone does this thing where it kind of comes down gradually over time, whereas women, it's just boom, all your estrogen just comes across and just stops. But men continue to make small amounts of estrogen as long as they are producing testosterone. Of course, it's going down over time, but they're still making some. So that's going to protect them some. But again, if you bring their testosterone levels back up to where they are optimally should be, you can protect men against heart disease for a long time. And we know this. This is a fascinating study, Catherine. I'm going to share this with you. You probably know about these studies, but you may not have put these pieces together because only recently did I put these pieces together. It made my head want to explode. Okay. Breast cancer and prostate cancer. Very similar diseases. They are solid organs of the reproductive tissue. Breast obviously common in females, prostate mostly men. Right? So they are both treated with blocking estrogen. Females, we take tamoxifen, right, which is going to be it's going to be an aromatase inhibitor. It's going to prevent your body from utilizing estrogen. In males, when we're giving testosterone blockers, so androgen blockers in prostate cancer, by stopping testosterone, we're also stopping the men's ability to make estrogen. Do you know how many years we keep people on androgen blockers or tamoxifen?
Well, it used to be 5 years, and then for some people, they made it 10 for breast cancer.
And why did they keep it at that number? Do you know? Because I didn't know this.
That's a good question. Why not a lifetime?
Because when you keep
your
someone
rates
on
of heart attack goes way up.
heart attack, because estrogen is responsible for preventing heart attacks. And basically what they found is if the tamoxifen and the androgen blockers, they do stop the cancer. If they only stopped the cancer and that was all good, then we should just keep people on them forever, right? But the thing is, as soon as you stop the estrogen, the heart attack risk starts to climb. And basically about 10 years is where those lines intersect, and you are going to have more heart attacks than you will deaths from cancer. So that's why they stopped it at 10 years. So yeah, hormone replacement, we think of it as a lifestyle thing, but it's much more than a lifestyle thing. People come to me because they want to be thin and have sex, but it's about prevention of disease.
Okay, wait, but let's not discount that. We all want to be thin and have sex. Okay.
Absolutely. I encourage people to be thin and have sex.
Super important goal right there. Okay.
Vitality includes love, but but basically it's that if you lose these hormones, heart attack risk starts to rise almost immediately, and within about 10 years, you have enough accumulation of plaque that you start seeing events. So
the thing also to keep in mind, I mean, it's complicated because tamoxifen, especially if you're premenopausal when you get diagnosed with breast cancer, it sucks. It feels terrible. People feel terrible immediately, right away. Boom! It blocks everything. You're miserable. You can't sleep. Sends you right into So I mean, it's such a drag. I honestly don't know. So back when I did breast cancer, we would have to have these discussions all the time, right? Because it's like you want to live, but at the same time, you don't want, an extra day of being miserable. That's really a tough thing to measure, right? Yeah. One thing to keep in mind for people thinking about hormones is that, and this was put to rest a long time ago, but there's still a lot of confusion about it. So the 2002 study that made everybody get off of hormones because they thought that hormone replacement increased your risk of breast cancer, that was all debunked. And without getting into how or why, I've talked about that on the podcast before, but I personally am on hormones happily. And of course I get my mammogram. So everybody go get your mammogram. If you're over 40, you have to have one every year. And I don't care who's going to be mad at me for saying, I don't need it. You absolutely have to have it. We save so many lives. I don't even want to talk about breast cancer. But anyway, going on hormones does not increase your risk of breast cancer. It is true though, if you do get a breast cancer, they're going to take you off your hormones because breast cancers, most of them have receptors on them that will stimulate growth if you continue to be exposed to hormones, which is why tamoxifen exists, why they're going to take you off your hormones if you actually have breast cancer. But it does not increase your risk. So go ahead, feel happy, sleep, have great sex, be strong, but also get your mammograms. Absolutely. Yes. Really important. If you're high risk, it's another discussion also with your doctor. So, but anyway, absolutely. Sorry, a little diversion there for just a moment since,
Yes, I absolutely agree with that. And I second all of that. All of my patients get mammograms yearly. It's important. But hormones do not cause an increase in breast cancer. Like you said, WHI was a very unfortunate study that led to a lot of unnecessary suffering. And the pendulum is finally swinging back to what I think is a little bit more of a sane area. But everything you said, I totally agree with.
Yeah. Okay, so back to longevity. So, can you talk about the various treatments that you recommend in your clinic?
Yeah, absolutely. So, generally speaking, I do believe that hormone replacement therapy is the foundation. I think
Mm,
that most people would agree with that. I think hormone replacement therapy and management of obesity and high blood sugar, those are the two things that are the
okay.
foundation. Now, again, referencing Peter Attia, his theory is he's like, if you don't have your metabolic health in order, he's like, don't even come to me for anything else. He's like, until you're working out, that means both weight bearing and cardiovascular workout on a regular basis. He's like, I'm not going to give you anything else because you have to get your house in order first before we start adding
Right.
other things on top of it. And I agree with that wholeheartedly. I also, not all my patients will do that. And I think you do have to meet people where they are sometimes. But exercise, when we talk about, earlier when we talked about that factory and genes turning on and off, one of the major things that turns your genes on and off is exercise. And there was a
Yeah.
recent study that came out that said that vigorous exercise reduced colon cancer recurrence as much by the same percentage that surgery does. When you have a disease which is driven by insulin, which a lot of oncologic or cancer is driven by high blood sugar. High blood sugar is inflammatory. Inflammation
Mhm.
irritates cells, and the irritation of the cells can then lead to replication of the cells and eventually cancer. So if you can keep your blood sugar under control, and that exercise is a major way to do that, that is the first step. Then GLP-1s, absolutely, that's going to help with blood sugar and
Sure.
obesity, absolutely. And then the hormones, and then on top of that, then you start getting into the stuff that's a little bit more, I don't want to say like out there, because I think there's some good science behind them, but things like rapamycin, things like some of the peptides that are coming out. I think that the science on rapamycin is probably accurate. I think so. Taking a
So,
step back
explain what that is and how you use
for
it.
our viewers, yes, rapamycin is a molecule. It was found on the island of Rapa Nui in the Pacific, which is Easter Island, in some kind of like volcanic pool somehow. I don't know the exact origin story, but it was originally used as an immune suppressant for transplant recipients.
Mm.
And then people started noticing that it seemed to have additional effects. At differing doses, it seemed to be able to extend life. And these studies have now been done in everything from single cell like yeast up, nematodes, which are little tiny worms. It's been done in rodents. It's been done in primates, dogs, cats, every species except for humans, which of course is the rub because humans are different. But these studies have been replicated in almost every species, showing that rapamycin activates a series of genes called the sirtuins, which is a family of genes that's responsible for telling our bodies, telling our genes to clean house, for want of a better word.
Mm.
So when our body is under stress, because these same results can be activated with extreme fasting, which is if you cut your caloric intake by like 30%, your body is like, hey, there's a famine, we've got a problem, we need to conserve and be very careful about what we're doing. And it activates the same gene pattern, these sirtuins. And basically what happens when these genes are activated, they go, okay, we've got a crisis on our hands, and we need to make sure that we are doing everything in just as sharp and careful a way possible. We're going to clean out all the proteins that are kind of cluttering up the cells that aren't doing anything. We're going to make sure our mitochondria are functioning correctly. And it creates an environment in your cell where your DNA is functioning, where your genes are functioning better. When we give rapamycin to animals, it extends their lifespan about 30%. And it's a healthy lifespan. It's not that they're getting sicker and sicker and sicker, they just don't die. It's that they remain healthy when they get about 30% more life. Now, studies are ongoing in humans, but the thing about a human study is it takes like 130 years to do, right? I mean, you can't, like, humans have really long lifespans, or I guess maybe we don't. We consider them long because they're ours, but we're not going to get human data back any reasonable amount.
Right, right, right. So,
So
how
there's a
is
lot of different.
rapamycin is a protein? Is it injected? Is it ingested?
It's a
How do you?
pill. It's a pill, and it's
Okay.
in pill form where you cycle on and off of it. So there's a bunch of different protocols for how you cycle and when. It's not something I started doing commercially in my clinic because I'm nervous, but
Mhm.
I do believe the science is there, and for myself and my loved ones, I think it's a reasonable thing to do. Again, not FDA approved. There's no human trials, but I think that the science is probably there.
Is that something that people can actually buy at home or no, not yet?
Oh, well, yeah, you need a prescription. I mean, it's
Ah, okay.
tachylitis, so you need a prescription for it. It's not crazy cheap. It's a month is going to be about $150, so it's not
Oh,
cheap
wow.
medication.
Okay.
But does it work? We don't have human studies, but every
Right.
single animal from yeast to gibbons, responds to it. And that's a pretty
Interesting.
broad swath, so I think that is something which could be
That is
done.
really interesting.
Yeah.
Are there any supplements that you recommend people take?
Oh,
Because
yeah.
I was recommended recently. I had Dr. Richard Baxter on the show
Yeah.
a few weeks ago, and he recommended taking NAD plus and alpha
NAD.
glutarate.
Oh,
And I'm kind of curious to know whether you agree with that, or
yeah.
is
Yeah.
that kind of yeah.
Yeah, NAD, that's a fascinating molecule. And again, for our non-medical folks, our bodies burn sugar, right? Like we use glucose. That's what gives our bodies its energy. And the way that we turn sugar into energy, we use there's this molecule called NAD, and we add phosphate groups to it and they swap around. But suffice it to say that NAD is the workhorse molecule that allows us to actually utilize energy from the food we bring in. It's the last common pathway. When I say last common pathway, what I mean is, let's say if you eat broccoli, you eat a steak, you eat a chocolate bar, all of those foods are all going to eventually be broken down to some type of glucose molecule that then is going to eventually be broken down, fed into NAD, and then NAD transfers the energy to other proteins. It's rough and incomplete, but the rough idea. So the idea is, well, if there is something wrong with your energy, your capacity to manufacture energy, then it doesn't really matter. This is the theory again. It doesn't really matter where the error is in this whole long, complicated chain. If you can make the last step more efficient, then theoretically you can solve the energy transmission problem without knowing where else it is in the chain. That's the idea behind it. What do I think of the science? I think that NAD works really, really, really well for about 20% of people. And for most other people, it does nothing. I don't think it's going to hurt anyone. So I think it's one of those things is a reasonable thing to try when you've got a patient who's struggling with any type of difficulty, getting energy into their system. Anybody who's tired all the time, who has a lot of trouble building muscle, who's having trouble, like they're sleeping too much, you give it because maybe getting that last step more efficient will do something for you. But I think there's some people for whom it's life changing. I don't think that we really understand what the heck we're doing. I think we're just pouring more gasoline on the body and going, wait, maybe it'll burn. But for some
That,
people,
or
it's
you'll
really,
just
really
pee it
helpful.
out.
Yeah, or else it won't. Yeah, exactly. So I think it is a molecule which, when we truly understand which people actually need it, will
Mhm.
be very, very powerful. I don't think we're quite there yet. I think there's a lot of really cool science being done. But I think when we figure it out, it'll be awesome. But I think that right now we're in that, throw it against the wall and see if it sticks phase. So I would say
Right.
with
So
NAD, try it.
it's harmless. And if you
Yeah.
are kind of lethargic or whatever, you're hoping to get your energy back up, it's certainly worth the trial, right?
Do 90 days. If you feel
Yeah.
better, awesome.
Interesting.
And if you don't feel better, then that is not going to be something that helps you. And that's okay. So on a limited basis, I use that with my patients who have, like, a lot of times I have noticed there seems to be a connection between people who are not adequately metabolizing thyroid hormone and the need for excess NAD. That is a
Mm.
clinical observation. I have no data behind that, and I have no
Mhm.
pathway to explain that. But it does seem that my ladies who come in with like Hashimoto's and stuff like that
Yeah.
tend to do well on NAD for whatever that's worth.
Interesting. So, is there anything else we have not covered that you want to mention?
Yeah, one thing that I like to kind of toss out there, because I think that people need to have a little bit more of an understanding of this one topic. This is one of my little soapboxy things. Peptides. So the word peptide is thrown around all the time, right?
A ton
And it's a
lately,
word that makes me
especially.
crazy because it means nothing, right? So the way I think about, the body, your body needs to be able to communicate with itself, right? You got, millions and millions of cells. They need to be able to communicate with one another. They obviously can't read. They obviously can't see. They can't hear. So the way that your body communicates with itself is by sending chemical messengers back and forth. And a lot of these take the form of peptides. The word peptide just means a molecule that's built on a certain backbone. A lot of hormones are peptides, and a lot of peptides are hormones, but not all. But basically, when we say peptides, what we're talking about is co-opting the body's natural messaging system in order to get the body to do specific things, which is
Right.
brilliant. But it's very important that people understand that this is not benign. We are using there's no difference between taking a peptide and taking a hormone and taking a drug. They are all chemical messengers that are going to try and get the body to do something. Now, do I think that some of them are very, very useful? Yes. Do I think we know enough about them to be giving them? not many, and they're being thrown around like water, and you got to be careful. But I
Yeah.
guess what I'd say is, when you see a clinic offering peptides, do not in your head be like, this is natural, and therefore it's safe.
Right.
That's a drug
No,
like any other.
it's
Doesn't make it
their
wrong.
drug. And so, I mean, a peptide is just a protein. And
Yeah.
and actually all that meat, that's all, it's the same thing. Peptide is the same word as protein. But GLP-1s are all peptides and very
GLP-1s,
handy, and they've been well studied, and they're FDA approved and blah, blah, blah. Right. And so a lot of what people are offering are other peptides that are signals in the body that may be great and maybe not. And we don't have enough data about a lot of them. Although there are, a lot of promising ones. I'm not a peptide expert. I was actually thinking about having someone on the podcast to talk about peptides.
Oh,
but
that's fascinating. I mean, it's fascinating science, and
it is. It's really
biochemistry at its most basic.
interesting, right?
Yeah.
But like everything else, you want to make sure you're not taking any risks or doing any harm. And so when Dr. Waples and I are talking about these things, we ourselves are thinking, okay, would I do this for me? Like, what are the benefits? And am I risking anything bad? If I'm risking anything bad, we're not going to do it. And we would never recommend it for our patients either, because it's like, well, there's just not enough studies to know that this is safe. So, the reason that I thought NAD was interesting, this was recommended by this other doc, and I did my research, and from what I could tell, it could at least do no harm. It might be helpful.
I think that's fair.
So I'm like, okay, it's safe
harm.
to take. I don't think I'm going to have any, negative side effects. There's no risks of increase some awful disease or something.
Yeah.
So, but when you get into peptides, then this is really a little bit different, because these are very potent signals, and you can take a teeny tiny little bit of peptide and change a lot in your body very quickly. And we've seen that with the GLP-1s. I mean, I can attest to the lowest dose of tirzepatide made me like lose 20 pounds. So
they're not subtle. Just because
they are not subtle.
And peptide doesn't mean it's gentle.
Right. So it's really an interesting topic, and there's probably a lot to explore there, and maybe we can do a little research and come back and talk a little bit about that. But anyway, it's been so great talking to you again. Can you let our audience know how to reach you, either on your socials or your website or whatever?
Yeah. So, I mean, if you want to learn about our practice, it's Restor Medical Spa, which is RESTOR, no E, Medical Spa. So you can find us at www.restormedicalspa.com. You can reach out to me at LinkedIn. It's Dr. Flora Waples. There's only one of me in the world. There's not a common name. You'll be able to find it. You can message me on LinkedIn at any time. And those are really the two best ways to get in touch with us.
Okay, fantastic. And we will have links to those in the show notes. So, Flora, thanks so much for joining me again today.
Oh, it's such a pleasure. Thank you so much for having me.
If you've learned something and like what we're doing, please tell your friends and give us a 5-star rating in your podcast app. If you have a question or a crazy story of your own you'd like to share, please send an email or voice recording to info@drkatedee.com. That's DRKATEDEE.com. Or reach us through the website MedSpaMayhem.com. And read the book. MedSpa Mayhem is available everywhere books are sold. Thanks for listening. This has been MedSpa Mayhem with Dr. Kate D. We are so grateful you're listening, and we hope you've learned at least one fun or possibly disturbing fact today. Don't forget to hit subscribe on your podcast app and leave us a 5-star review. And read the book. MedSpa Mayhem is available everywhere books are sold. Links and more can be found in the show notes and on medspamayhem.com.